Okay, so this talk is on shock in the pediatric transport environment. Again, we'll give a little bit of a background. We'll classify shock, but most importantly, trying to tailor this talk to the pediatric transport environment. We'll end by going over the latest shock algorithm, latest meaning a 2007 publication. So really, when you're thinking about shock, really what shock is an imbalance of what our major ICU goal is. Regardless of the patient that we have, we want to ensure in the ICU that we have adequate oxygenation and perfusion of our tissues. And that's in a balance. And if our metabolic demands far outstrip our ability to meet the metabolic demands, then obviously there's an imbalance and shock will ensue. So what is shock then? It results from inadequate oxygen delivery or impaired utilization. Now when your cells aren't getting oxygen and they aren't getting nutrients, then what happens? Obviously the tissues are going to become hypoxic, the cells aren't going to function nearly as well, and your cells will die, and they'll die of one of two ways, either programmed death or cellular necrosis. Now it's not necessarily a problem with blood volume, cardiac output, and I had cardiac output twice there. It can be through a number of different reasons. Sometimes it's as far as the cellular reason or level, as far as cyanide toxicity, where everything is completely adequate in the body except the cells, quite simply, are not able to utilize the oxygen. So again, it's about oxygen delivery and consumption of oxygen. Oxygen delivery is denoted as DO2, delivery of oxygen, and consumption is VO2. So it's a law of supply and demand. It's as simple as that. So this nice little chart here delineates the difference between delivery and consumption of oxygen in this balance, DO2, VO2. One of the things that can drive up oxygen consumption is when our metabolic demands are increased. Well, what are instances when we have increased metabolic demands? Well, when we're febrile, for example, or when we're fighting an infection and our body requires more fuel in order to rally the recovery. Conversely, if the body is cooled, like in hypothermia, you have decreased oxygen consumption because your metabolic demands are decreased. That's on the VO2 side. But on the delivery of oxygen, there's several things that we have to think about. And again, cardiac output, we keep on going back to that equation I told you. Cardiac output equals heart rate times stroke volume. Again, our oxygen delivery is contingent largely on our cardiac output. But it also is contingent on our hemoglobin. Hemoglobin being the major oxygen transport system in the blood. And if you have low hemoglobin, oxygen cannot bind appropriately, and therefore you will have a difficult time meeting the physiologic demands of the body because you're not able to bind the appropriate hemoglobin. Okay? Now here's one way of looking at it from more of a scientific or a math perspective. When you think about delivery of oxygen, DO2, it hinges on our ability to deliver blood to the tissues and our ability for oxygen to be delivered in that blood. And cardiac output, again, from last talk and what I mentioned earlier, is equal to heart rate times stroke volume. When we talk about arterial oxygen content, the majority of our oxygen is bound to hemoglobin, and that's why hemoglobin is very important. But part of it is dissolved into the blood, and that's your PaO2. But with a clinical exam, you should be able to answer the question, is the cardiac output appropriate in this patient? And there's various triggers to suggest that it may not. And with a simple SAT monitor and a CBC or blood gas, we should be able to determine the SATs as well as the hemoglobin. So through not a whole lot of work and with a little bit of clinical acumen, we should be able to decide, are there any impairments in oxygen delivery for our patients? Now, typically when we think about oxygen consumption, VO2, we don't really, we are really not afraid that we are consuming too much oxygen because our body has a tremendous capacity to deliver oxygen in a way that there's no possible way in a healthy individual that we are able to utilize all the oxygen that's delivered to our tissues. So when I say that, perhaps I'm exaggerating, but when we do a mixed venous SAT on our patient, so that is venous blood that returns, typically that mixed venous SAT on our patient is 70%, which means that there is only a 30% reduction of our SATs as it goes from the arterial to the venous side, meaning that all the oxygen that's delivered to our tissues is really not taken up by the cells. So in point 1 there, you can see that delivery of oxygen is typically significantly greater than what is required. But if the oxygen consumption increases dramatically, or the delivery of oxygen decreases, then all of a sudden we may run into an imbalance. And if DO2 delivery drops below a critical level, all of a sudden your oxygen consumption becomes dependent on the delivery, and that's when hypoxemia occurs, or tissue hypoxia occurs. So let's look at oxygen consumption and things that can drive up oxygen consumption. Interestingly, and things that you would suspect on the bedside, hypercatabolic states like burns and sepsis, for example, will increase your oxygen consumption dramatically. Things that you may have not thought about, for example, like changing the position of the patient, doing the chest x-ray, can do the same thing. Interestingly, you see the second last one, a bath. I have seen this a few times where you've had a patient who's relatively unstable and had an acute decompensation during a bath. And the reason why is that you're acutely increasing their oxygen consumption requirements. Now, if you have a patient on edge, for example, and they're not able to account for those increases by increasing their delivery, then you're going to have a patient that gets into trouble. Now, there's a few medications that can also increase your oxygen or your oxygen consumption. You can see the catecholamines that we routinely run in our ICU can drive up oxygen consumption quite dramatically. Epinephrine and dopamine and norepi are common culprits. As you can see, though, we can also decrease our oxygen consumption by decreasing the metabolic demands of the body, by hypothermia, for example, by anesthesia, by taking over ventilation, for example, or paralyzing the patient. All things that will decrease the oxygen consumption because we're decreasing the metabolic demands of our patients. So when you're thinking about shock states, you can generally think of them in two broad categories. One is a compensated, and the second one is the uncompensated. Now, it's important to know that most people can recognize uncompensated shock states. That's fairly easy to pick up. What is a little bit more tricky to pick up and what is often missed are compensated shock states. It's important to pick these patients up because these patients have a high risk of slipping into the uncompensated shock states. And the thought is that if you aggressively treat these compensated patients earlier, then their risks of slipping into uncompensated shock states dramatically decreases. Why are compensated shock states often overlooked? Well, because blood pressures are maintained in these instances, and the compensatory mechanisms of the body start kicking in. These are the kids that are cool because they're vasoconstricting. They're trying to shunt blood to the important organs, the brain and the heart, and at the expense of peripheral perfusion. These are kids that aren't peeing very well. They're releasing their endogenous catecholamines from their adrenal glands. They're increasing their heart rate. Again, cardiac output equals heart rate times stroke volume, so they're compensating this way. So again, these are sick kids. They're compensating, but their ability to compensate does have limits. Depending on what you read, there's other ways to organize the different types of shocks. You'll see the shock algorithm where S is septic, H is hemorrhagic or hypovolemic, O is obstructive, C is cardiogenic, and K is anaphylactic. You can think about concepts too, is that sometimes maybe it's a pump shock idea, meaning that it's of a heart origin. Maybe it's a prime shock, so it's a preload problem, a patient who's very dry or bleeding. Or maybe it's a pipe shock, talking about distal vessels being vasodilated and vasoplegic, being leaky. So there's different ways to organize how you think about shock, and you can pick one that fits best with you. But again, keeps on going back to the point of recognizing a shock early so that you can treat it effectively. With neonates, I believe it's discussed in further details in other talks, you need to consider other things. Endocrine emergencies. Endocrine emergencies do occur also in pediatric patients, but they're a little more subtle in neonatal patients because oftentimes they're undiagnosed. Adrenal disorders, thyroid disease, hypoglycemia, inborn errors of metabolism, and congenital heart disease and the others. So again, neonates cast a broader net in your differential when considering, is this patient in shock or not? Monitoring is a very important element for all our patients in pediatric transport, but in shock patients it's very, very important because shock patients can significantly get worse even if they're resuscitated adequately, and the earlier you can detect a downward trajectory, perhaps these are sentinel times where you can interject and change outcomes. One of the things to think about, and as I talked about earlier in this talk, is our delivery of oxygen and our oxygen consumption balance. And there's things here that we can do at bedside to help us discern, is this a delivery problem or this is a consumption problem? And I put those out on a chart for you to consider. Lactate is quite interesting. There are several reasons why a pediatric patient will have an elevated lactate or lactemia. When you look at the adult literature seems to suggest that a lactate of around 5 is associated with poor outcomes. Again, a lactate is only one number, but when considered in a patient that is presenting with shock, a lactate can be a very useful indicator, and it can also be a surrogate for whether the treatment that you're initiating is in fact helping or not, aside from the clinical indications that you will be seeing. So clinical signs. When we talk about distributive shock, this is another way of classifying it. This is typically thought about as a pipe problem. Your vessels are vasodilated, they might be leaky, vasoplegic, and so there's a number of different disease entities that can present with distributive shock. So again, here this talks about anaphylaxis and spinal cord injury. For spinal cord injury, what can happen is that it can affect the way your spinal cord communicates with your blood vessels, and because of the injury may not be able to vasoconstrict the vessels appropriately. Septic shock is oftentimes thought of under the distributive category. Septic shock can cause a pipe problem. We also know that sepsis can also cause heart problems as well with this unknown myocardial suppressant factors. The interesting thing with septic shock that's different in kids than it is with adults is that kids can present with two different types of presentations. From an adult perspective, typically adults present as being warm. They they come, you put your hands on their hands or their legs, and they're massively vasodilated and they feel very, very warm. And kids can present like that. But kids can also present in cold shock. And in cold shock with kids, their compensatory mechanisms start kicking in so that they are vasoconstricted in their peripherals, so that when you feel their hands and their legs and feet, they are very, very cold, and they are effectively shutting down their circulations in their peripherals while trying to maintain vital perfusion to their core and to their brain. So again, sepsis in kids can either be cold or warm shock. Cardiogenic shock, we've talked about that previously with acute heart failure. And hypovolemic shock, again, is a different entity. This is a preload problem where the heart is functioning okay. Typically what happens is that systemic vascular resistance goes up because it tries to compensate, so they start clamping down. Typically they'll feel cold in the extremities. The problem is that the pump isn't primed and they need volume. And we typically see this with bleeds or significant dehydration. So what is the treatment? Well, the treatment depends on the type of shock that you're dealing with. One of the important aspects of most shock therapies is fluid. And this is giving rapid fluids. These are boluses. These aren't fluids that are running over half an hour. When volume is indicated, it means volume that's bolus quickly and typically at 20 mils per kilo, unless you're dealing with cardiogenic shock, and then it's going to be 5 to 10 mils per kilo. Every time you give volume to a patient, regardless of the shock etiology, it's very important to reassess them. Are they responding to the volume? With a cardiac patient, was it too much volume? Is the liver getting larger? Again, the debate is always what is better for fluid therapy, colloids or crystalloids, and there is emerging evidence that colloids such as albumin or synthetic colloids are perhaps causing harm in critical illness, and therefore we will consistently advocate crystalloids or Ringer's lactate, normal saline, rather than colloids. General principles, again, depending on the pathophysiology of the shock, things to think about: does your patient require inotropic agents? Does the heart need help to squeeze? Chronotropic agents: does the heart need assistance in increasing the heart rate? Again, cardiac output equals stroke rate times volume. Vasopressors: is your patient very vasodilated and warm? And do we need to help with vasoconstriction? So you'd be thinking about norepi here, for example. Or vasodilator, perhaps your patient is so clamped down. Is there any indication to help them open up, to vasodilate them? So we talk about specific agents and catecholamines in particular. We're thinking about dopamine, norepinephrine, epinephrine, and dobutamine. Typically in the PICU, we'll be using a peripheral dopamine in the transport environment because it's much safer to run than epinephrine in a peripheral line. Epinephrine at lower doses is thought to be more of a agent to help with heart squeeze and to increase heart rate, and norepinephrine at low doses is thought to help more with vasoconstriction. Luciotropes are thought as helping the heart relax, with milrinone as the prime luciotrope that we use. Again, never use luciotropes unless you've had discussions with medical control. And vasodilators, typically in the acute period, we'll think about running nitroprusside. So catecholamines will help, as we talked about earlier, to squeeze the muscle. They will help increase the heart rate. They can also vasoconstrict. And the whole idea about adding catecholamines is to increase the delivery of oxygen. But catecholamines, imagine your endogenous catecholamines. You've seen a bear, and you can imagine what that does to your body. Well, the same thing happens with exogenous catecholamines. You're going to increase oxygen demand. and consumption. You can increase pulmonary vascular resistance, so your patient that comes in with a history or clinical signs of pulmonary hypertension, use catecholamines very, very carefully. And catecholamines can also evoke dysrhythmia. So if you have a patient in cardiogenic shock that is not in sinus rhythm, again, use it very, very carefully and in consultation with medical control. Lusiotropy, again, medications to help relax the muscle of the heart, is typically considered with milrinone as the sole agent. Milrinone is an excellent drug because it helps decrease pulmonary vascular resistance. So for patients with pulmonary hypertension, we often have them on milrinone. It also decreases peripheral vascular resistance. And in many shock states, this is not going to help us because our patients are already quite vasodilated. It helps to relax the muscle, and oftentimes it's not used on its own, but it's used together with catecholamines. It is a weak muscle squeezer and it has a long half-life. But again, don't start milrinone unless you have consulted medical control. So nitroprusside in some shock states, vasodilating the patient is going to be helpful, but in the most common shock states being hypovolemic, dehydration, and septic, for example, nitroprusside is not the agent you're going to consider. So talking about algorithms, again, I thought it was a 2007, it's actually a 2009 publication on sepsis guidelines and how to treat. And what's really interesting with this sepsis algorithm, for example, if you look on the left-hand side and the timelines, you can see that when you're dealing with shock, and most importantly septic shock, because that's going to be probably the most common that you're going to be sent to, is that the way to treat it effectively is to treat it quickly. And you can see that by the 15-minute mark, we have already given volume once, twice, and considering inotropes. That's 15 minutes into presentation. So again, when you have a septic shock patient in front of you, you need to treat aggressively, you need to treat quickly. So obviously the most important thing is to establish IV access, and if that's difficult, and in some of our patients who are peripherally shut down and IO is necessary, the next part of our resuscitation is giving volume. Again, with cardiac patients, we're not going to be giving the same amount of volume, but we are pushing boluses 20 cc's per kilo over a short period of time. We're also trying to assess what has caused this shock. In sepsis, oftentimes we will have a story that's strongly suggested, or we're going to be on the IFT going to a center where they have already started treatment for it. But this algorithm demonstrates to give volume quickly and to give a lot. Of course, we have to correct the electrolyte disturbances and any glucose disturbances that we see as well. By the 15-minute mark, but typically this time is going to be unrealistic. It's going to be a little bit after that. If you find that you don't have a clinical turnaround after giving volume, then you need to consider introducing catecholamines fairly quickly. Now, it helps you down here on what catecholamines are going to be helpful. But again, don't start catecholamines until you have discussed it with medical control. And epinephrine is a great drug, but in the transport environment, running epinephrine peripherally is a little bit scary. So we would often start with dopamine, because if it goes interstitial, it's not going to have nearly the same deleterious effects as epinephrine. And the way to think about it is, if you have a child in cold shock, it means that they are vasoconstricted. And really what their heart needs is to be supported. And epi is a great heart support drug as well as dopamine. If the patient is warm, it means that they're vasodilated, and likely the therapy that they need is to help tighten up their peripheral extremities. And the way we do that is with norepi, because norepi is a vasoconstrictor. So in conclusion, shock is not equal. The pathophysiologic processes are different, It does boil down to an imbalance between DO2, VO2, but I recognize that there's many different types of shock. Secondly, try to categorize your patient. This will be very helpful. Is it a prime problem? Is it a pump problem? Is it a pipe problem? Or you can use the shock algorithm. There's different ways to classify it, but if you have a patient that you suspect is in shock, it's very, very helpful to be able to categorize it because the treatment is going to be different. Again, think about DO2, VO2 imbalances and how are you going to assess those clinically. And with all shocks, the most important thing is to identify shock, to categorize what type of shock it is, and then to treat early and aggressively. Run the Saskatoon